Hi everyone, and welcome to another Corsmed MRI video. Today we're going to look at cardiac MRI, and specifically we're going to look at viability and myocardial infarction. This is going to be a two-part video, so the first one is going to be on the cardiac function. Let's go. Here we have the Corsmed MRI simulator, which is where I'll demonstrate how to run this protocol. In MRI, we always face a trade-off between three key metrics: scan time, resolution, and signal-to-noise ratio. If we improve one of these metrics, it reduces the performance of the others. So how should we prioritize when it comes to cardiac viability MRIs? We use cardiac viability MRI to find out if damaged heart muscle can still heal. This only works if we can clearly see the difference between scars and healthy myocardium. Therefore, you may want to slightly prioritize SNR, followed by resolution, and lastly scan time. Prioritizing SNR ensures you can clearly see the bright scar tissue against the dark, healthy muscle, which is the main point of viability scanning. Good resolution comes second, since measuring how deep the damage goes into the heart wall, which tells us if recovery is likely, requires enough detail to see thin scars, which measure just 1 to 2 millimeters. However, this is not a strict rule. The right balance always depends on the needs of your patient and your scanner. If your patient can't hold their breath well, or has an irregular heartbeat, for example, you may need to focus more on faster scan times and use techniques that can get accurate images, even with these challenges. In this first part of the viability protocol video, we will focus on cardiac function and morphology. Function is about the pumping action of the heart, and morphology is about studying the shape, structure, and size of the heart. So what medical conditions are we looking for when examining these two aspects of cardiac viability? Two common conditions are pericardial and pleural effusions. These are best detected with a black blood sequence, which nulls blood signal to highlight fluids and fat. Other common conditions are thrombi and cardiomyopathies. These show up well on a bright blood sequence, which show clear contrast between chambers and myocardium. We also have functional conditions like wall motion disorders, systolic dysfunction, and mitral regurgitation. These can be clearly seen on a CINE SSFP sequence, which captures real-time heart motion and ejection. This CINE sequence is often done in multiple views, including 4-chamber, 3-chamber, 2-chamber, and SAX stack. Now, let's start setting up our cardiac protocol. We need to make sure that we have switched on myocardial infarction as a pathology in the simulator. Regarding the patient positioning, the patient should lie on their back in a supine position. We will ask the patient to inhale, exhale, and then hold their breath. That's why the breathing phase for our acquisition is set to breath hold at exhale. Before placing the patient in the scanner, we should also make sure to ECG-Gate the study. ECG gating means we use the patient's electrocardiogram to make sure we capture images at exactly the same time point in each heartbeat. If we capture images at different phases of the cardiac cycle, we would risk getting motion artifacts caused by the heart beating. In this case, we will use a normal RR interval ECG wave, meaning the ECG shows no arrhythmia. In a healthy patient, their heart should beat in a consistent sinus rhythm. But if a patient has poor heart condition, their heart may not have a constant interval between the diastole and systole due to arrhythmia, which changes the heart's rhythm. Such irregular heart rhythm will affect your images and make scanning harder. You may get artifacts from mistriggering. So take time while you position the patient to check that the ECG trace looks strong and stable. The ECG trace is basically your guide throughout the entire scan. So make sure it doesn't disconnect during positioning or due to patient movement. For the hardware setup, we want to use a cardiac coil. This means using a dedicated cardiac phase array coil to get the best signal. We also need a magnetic field strength of 1.5 Tesla or even 3 Tesla. A 3 Tesla scanner gives better signal and better resolution for cardiac scans. But 3 Tesla also brings more artifacts and gives more heat to the patient. That's why most cardiac magnetic resonance scans use 1.5 Tesla instead. The gradient strength can be 45 or 60 millitesla per meter. A strong gradient helps improve our temporal resolution, especially for CINE imaging. So that's our hardware setup. Now, we'll start by loading the localizers into our viewports. We will then scroll to a central slice in each view where we can see the anatomy of the heart clearly. We can now start adding our pulse sequences. So now we'll go find our protocol list and I'm going to search for my cardiac protocol. Here it is, and I'm going to expand it. The first 2 sequences we run will be the black and bright blood sequences. These are related to the morphology part of cardiac viability, the shape, size, and structure of the heart. The black and bright blood sequences will help us check that we positioned correctly and view extracardiac findings, such as pleural effusions and pericardial disease. I'll import them without position, so I can show you how to position them. The black blood axial is a hybrid T1 weighted sequence, which normally applies a double inversion recovery pulse. This makes the vessels, myocardium, and blood pool all appear completely dark. The myocardium, however, may look a little brighter or gray. That's because it's a still structure, unlike blood, which moves. Moving blood doesn't recover its magnetization in time to give a strong signal, which is why it shows up as black on this sequence. To plan this sequence properly, we'll take a sagittal and a coronal localizer and plan in the axial view. We want to see the area where the upper part of the lungs and the diaphragm appear clearly. Even in the sagittal localizer, we want a clear view of the top and bottom of the lungs. Here, we can see the lowest part of the diaphragm in the posterior section. And here we have the apex. These are our boundary structures. So this means when I choose the number of slices, I need to make sure I cover from the apex all the way down to the diaphragm. Then, of course, we'll center it properly. We can also reduce a few slices and scroll back and forth to make sure we're not cutting off the apex, and then decide on our resolution. Usually, we pick a slice thickness between 6 and 8 and a slice gap between 1 and 2. So, for example, if I want a slice gap of 1, I can increase the number of slices a bit. But here, I'll keep my gap at 2 and not add extra slices. This is usually an ECG-gated sequence, so we won't see missed triggering artifacts. But it is a free breathing acquisition, which can sometimes cause breathing artifacts, especially near the front of the chest. So let's switch on free breathing for our model and see how it looks. When planning this sequence, we should keep in mind that this is a hybrid T1 weighted sequence. This means it blends features of a slower gradient echo sequence with a faster spin echo sequence to give us a balance of speed and contrast. When a sequence is slow, we can apply partial Fourier or other techniques to speed up the acquisition. But if you look here, the acquisition time for this hybrid is only 48.6 seconds. So I will go ahead and save and run this sequence. Now, the bright blood sequence is planned exactly like the black blood. So we'll copy all slices and parameters from that sequence to match the number of slices, resolution, and so on. But this time, it's set up more like a pure T2 sequence. So we'll use slightly different parameters. The repetition time will be longer, and the echo time will be longer too. It is still gated, however, to improve motion control. This sequence is also especially sensitive to banding artifacts at 3 Tesla. So it's more likely to show disruptions at that field strength. Now, why are the black and bright blood sequences important? While these are running, I'll explain. Black blood sequences help us see extracardiac structures pericardial effusions, and fat infiltration. Bright blood sequences instead show intracardiac anatomy and chamber dimensions. And both of these sequences are complementary. Black blood helps with tissue characterization, while bright blood helps with chamber visualization. Let's now go ahead and review the first one that finished. This is the black blood sequence. We'll scroll through it quickly and check that we don't see any bright signal in our vessels, nor in other places where we expect liquid or blood, like the 𝗵𝗿𝗵𝗆 ducts, which you can see here and here. This is the aorta, and this is the vena cava. We see no signal, completely black. That's exactly why we call it black blood. Some people may choose to add fat saturation, and some may skip it. This depends entirely on your organization. In fact, some teams don't include the black blood extracardiac sequence at all. They might be okay with what they can see on just the bright blood sequence. And in some cases, like this one, our localizers cover the patient extensively in axial, sagittal, and coronal views. So some sites may even skip both sequences entirely just to speed up the protocol. It's really up to the person or team setting the protocol. They decide whether to prioritize one over the other or whether to run both. So you should always check with your practice manager. Here, we can compare the sequences side by side. I'll take a slice where we see part of the heart and also part of the liver. As you can see here, the liver and 𝗵𝗵𝗵𝗃 ducts appear bright. Our aorta lights up and the blood pool lights up. But in the black blood image, we see the opposite. So let's now go ahead and start the function assessment. In cardiac MRI, we usually study the function of the heart, mainly the left ventricle, unless the clinician tells us otherwise. If we notice anything unusual in the right ventricle, then we run a separate dedicated scan for that area. For this first video, we'll focus on the global function of the left ventricle. So let's go back to our protocols, head into the cardiac folder, and this time we'll select the function and morphology section. First, I'll start by adding the 3 plane localizers because I want to capture some of the pseudo chambers in the images. One thing that makes cardiac MRI especially tricky is the heart's twisted position. As you can see here, the heart lies at an angle. Its long axis doesn't align perpendicularly with the main axis of the body. So the heart is actually twisted from left to right and from the back of the body towards the front. Because of this, we can't rely on pure planes like axial, sagittal, or coronal. Instead, we work with pseudoplanes, and we will name them based on the chambers of the left ventricle that we see. For example, with the first of the 3 plane localizers, I'm going to acquire a 2-chamber view. I'll open the sequence, right-click, and select perpendicular, because this isn't a standard plane. Then I'll rotate my field of view so it runs roughly through the middle of where we expect to see the mitral valve. Next, as we scroll down toward the apex of the heart, I want the slice to pass through the apex and go straight into the mitral valve. So we're now set up to acquire a 2-chamber view because we're cutting through the left atrium, this part right here, and the left ventricle, this area over here. It's easy to recognize the left ventricle because it's the only chamber with a thick wall around it. That wall is the left myocardium. So we're now going to check our field of view. Since these are just localizers, we don't need high resolution. The acquisition time is only 1.9 seconds. So it's really fast and usually done with free breathing. Now I'll check the phase encoding direction. It should be anterior-posterior, and then I'll save and run the sequence. Next, I'll clone the sequence and plan a pseudo short axis. This time, I want to cut more or less perpendicular to the two-chamber plane I just acquired. You can see that I now have the two-chamber in the middle viewport. I'll right-click, choose perpendicular position, and set my slice parallel to the mitral valve plane. In this image, we're also aligned parallel to that plane, and we're angling the slice more or less like this. I want to take just 3 or 4 slices, some a bit above and some a bit below the mitral valve plane. I need to include a bit of the ventricle, but I also want to see the area just below it, where we find the aorta, pulmonary artery, and the left atrial appendage. This helps me know what to exclude when planning the final two-chamber view. So I'll go ahead and save and run this pseudo short axis view, which I want to end up right over here. Now, we can finally start capturing the real CINE images. As I mentioned earlier, these are acquired in the axial position. So I'll make sure the patient knows to breathe in, breathe out, and then hold their breath. Here we have our short axis view, and I want to draw your attention to this particular image. This image includes many important circular structures. This part over here is the aorta. Right next to it, we see the pulmonary artery. Over here is the left atrium, and you can see the left atrial appendage, this small part of the chamber that extends sideways. The left atrial appendage is important in patients with arrhythmia or atrial fibrillation. It's a common site where thrombi, small blood clots, may collect. This can make it especially risky in these patients. And finally, we have the right atrium over here. You can also see the inferior vena cava entering this chamber. This image is the most important one in the series. If you're unsure when or how to take the short axis images, it's best to start with a few extra slices. Usually, taking 3 or 4 slices is enough to make sure you're covered. Let's go back to our standard protocol. I'll open the cardiac folder again and choose my first CINE sequence, the one labeled two-chamber. I'll add it without position and then close the planning panel. Since this is not a localizer, I'll rename it and then click on Save. In a real scanner, CINE sequences are always triggered with the patient's ECG. That's not the case with the system I'm using here, but we can still set the number of cardiac phases. Usually, we select around 20 cardiac phases for a CINE sequence. This gives us enough frames to show the full cardiac cycle, especially the end diastolic phase, which we use as the trigger point for acquisitions. Until now, we didn't need to worry much about resolution, gating, or breath holding. We were just scanning localizers or checking for extra cardiac anatomy. But now we're diving into the core of cardiac magnetic resonance imaging. So it's critical that we have a patient who can breathe in, breathe out, and hold their breath repeatedly, usually 15 to 20 times in a row. That can be quite tiring for the patient. We also need to make sure we have a good ECG trace and that our CINE sequence is properly triggered to match it. Now let's open the CINE sequence. First, I'll copy the image position from the two-chamber view since I already have a rough plan. This gives me a starting point that I can refine. To refine it, I'll show you a trick. We'll plan the full 4-chamber view first, not the 2-chamber. This is because the 4-chamber view shows all chambers simultaneously. So if we acquire this view first, we can use it to plan the 2 and 3-chamber views more accurately. To start planning it, I'll right-click and select Perpendicular Position. I'll position the slice to run through the middle of the mitral valve and then down through the apex. In the short axis image, I want the slice to sit lower than the top of the aortic root. At the same time, I want it to cut through this region here where we find the right ventricle apex. So what I want to do is angle this dashed line, which shows my field of view, so that it points all the way down to the right ventricle apex. Then, I scroll through to check that I'm following that line properly. I also make sure I'm going under the aorta in every slice. Once I reach the slice where the black donut appears, which is the left ventricle myocardium, wrapping around the blood pool, I want to be sure I'm right in the center of this donut. That means I'm cutting exactly through the middle of the left ventricle, which lets me get a full look at what's happening in this region. This view is really important. In textbooks, it's often called the snowman image because the structures stack up like a little snowman. Let me show you in the image viewer where we can see this snowman look. This part up here is the head, which is the pulmonary artery. The middle section is the body, which is the aorta. And the lower section, the pelvis or legs, is the left atrium. Once we've checked the field of view and resolution, the sequence is pretty much ready to go. This is a hybrid sequence, so some fluids will appear slightly bright, but the main contrast effect is still T1 weighted. Most of the time, we use a flip angle between 50 and 70 degrees. We often apply parallel imaging, specifically grappa, with an acceleration factor of 2. This will speed up our scan time. Here, we've brought it down to 28 seconds. If we increase the acceleration even more, we could shorten it further. One artifact to watch out for is susceptibility artifacts from metal implants. This includes things like loop recorders, pacemaker wires, or pacemakers themselves. In those cases, it can help to change the patient's position. One option is the Superman position with one arm stretched up. But an even better and more comfortable one is to lift the left arm above the head during the scan. This is especially useful for patients with loop devices or pacemakers. That's because those devices are placed in this area over here, which will get disrupted by artifacts during the CINE scan. In this case, we can already see the pathology here. But if an artifact appears in this region, we won't be able to see the pathology clearly. Now, we've just received our first 4-chamber image. I'll duplicate the sequence and continue with the 2-chamber acquisition. As you can see, we can now review the CINE image and clearly see all 4 chambers. The left atrium, right ventricle, and left ventricle. Notice how the left ventricle has a thicker layer of myocardium around it. We can also see part of the chest. There's a minor wrapping artifact, but it doesn't interfere with the anatomy. We can still evaluate the movement of the heart clearly, so we're happy with that. Next, I'll put my localizer 2-chamber view on the left-hand side of the screen. Then, I'll use the short axis image to plan the next step. Just like before, I'll copy the image position. That gives me a rough starting point, and then I'll fine-tune it by slightly rotating the field of view clockwise. I want to shift the slice away from the pulmonary artery so it doesn't show in the view. Then I'll angle this part of the field of view, like this, to clean up the alignment. This is going to be my 2-chamber view. Besides the positioning, we don't need to change anything else because we already set up our CINE parameters. So now I'll move on and plan the first LVOT view, or left ventricle outflow tract, also known as the 3-chamber view. There are 2 different ways to project this view. In this video, I'll show the most common one. The second method is only used for a special case, which is when we need to perform what's called a QPQS, a pulmonary versus systemic flow comparison. This technique uses phase contrast or velocity mapping, and it measures flow in both the aorta and the pulmonary artery. In a healthy patient, the flow ratio should be 1:1. What comes in should equal what goes out. But in some diseases, or when there's abnormal communication between the heart chambers, like between the atria or the ventricles, This 1-to-1 ratio doesn't hold. And that's where we can detect the issue by comparing pulmonary versus systemic flow. By comparing these flows, we can detect abnormal communication between the heart chambers. This helps diagnose conditions like pulmonary hypertension or a defect in the interatrial septum. We don't have phase contrast imaging available right now, so we won't cover that indication in today's session. Now, let's take a look at the two-chamber image we just acquired. It looks nice and clear. We can see the left atrial appendage here, and there's a faint view of the pulmonary artery that doesn't interfere, so we can see the appendage correctly. This is a key feature that tells us our two-chamber view is properly acquired. As you can see, we can visualize the entire left ventricle cavity. We don't see the right ventricle below it, which is ideal. Sometimes the right ventricle is so large, it appears beneath the left. You should try to avoid including it. But in some cases, pathology makes that impossible. For example, if I shift the slices slightly, like this, I'll end up including part of the pulmonary artery and the right ventricle in the image. So that kind of image is not accurate for a true two-chamber acquisition. This one, however, is a great two-chamber view. We can see both chambers, the left atrial appendage, and almost no pulmonary artery getting in the way. Now, let's deep dive into the left ventricular outflow tract, our aorta. That's this area here, also known as the belly of the snowman. So I'll angle the slice to pass through the middle of the left atrium and into the center of the aorta. Then I want to angle it so that it also passes through the apex, using either the two-chamber or four-chamber view. Next, I'll check the field of view to make sure it's large enough, which it is in this case. Then I'll click on Save and run this pulse sequence. Now, when should we repeat a CINE scan, regardless of whether positioning was good or bad? One reason is poor ECG tracing. If the ECG signal is off, you might see motion blur. The images won't look sharp, and the movement may appear delayed. When that happens, you'll see anatomical structures appear more than once in the same cardiac cycle, just delayed in time. That's exactly what we don't want. To show what that looks like, I'll clone the four-chamber sequence and run it with mistiming, just to demonstrate how mistriggering affects image quality. I will switch on Simulate Physiological Motion. So we are repeating the same four-chamber CINE sequence, just with mistriggering. Let's now run this pulse. As you can see here, while that sequence runs, our three-chamber view has just come in. We can see the aorta, the left atrium, the left ventricle, and part of the right ventricle right over here. One of the main things we should keep in mind while scanning is the risk that the patient might move or breathe differently. This can affect how clearly we see the endocardial borders. Later, we'll talk more about why that matters for post-processing. But for now, just remember that we need to see the inner edge, called the endocardium, and the outer edge, called the epicardium, clearly in the left ventricle. When it comes to the right ventricle, the myocardium is naturally thinner. We're mainly focused on getting clear images of the endocardium. That's the key requirement. We do look at the epicardium too, but it's more relevant in rare cases, like non-compaction of the right or left ventricle. So these are some of the situations that might lead us to repeat a scan. Here, for example, we've acquired a sequence with either mistiming or physiological motion. You can see the delay in the image frames. Let's now turn off the physiological motion option. I'm just going to switch it off so we can move on. Now we can continue with the rest of the CINE sequences, which are the short axis views. To plan these short axis slices, we'll need the four-chamber view, the two-chamber view, and the pseudo short axis. This will help us guide the field of view. If we copy the image position, we can immediately check how we've been planning. Or, if you prefer to start fresh, just right-click and select Perpendicular Position. We want to rotate the view so it's perpendicular to the posterior wall of the left ventricle on the 2-chamber view. And on the 4-chamber view, we want to be perpendicular to the interventricular wall, which is basically the interventricular septum. So here, we want to be perpendicular. Here, we also want to be perpendicular. Then, we will move our slice package to the middle of the left ventricle. Now let's set the number of slices. That usually ranges from 9 to 12, depending on patient size. For this case, I'll go with 10 and slightly shift the stack downward. For slice thickness, we want either 7 or 8 millimeters. To maintain a ratio of 10, set the slice gap based on the thickness. If you choose a thickness of 7, the slice gap should be 3. And if you choose a thickness of 8, the slice gap should be 2. Here, I'll go with a thickness of 7 millimeters and slice gap of 3. Now, we want to follow the same planning principles as for the other CINE sequences. We will aim for a short scan time per slice. In this case, the full short axis stack takes 1 minute and 24 seconds. So that means each breath hold will last about 10 to 12 seconds, which is manageable. I'm dividing that time across 10 slices. On your scanner, you should see the acquisition time per slice. That's your actual breath hold duration. We'll now save and rename this as our SAX stack, or short axis stack. Then we'll click on Save and run this pulse sequence. Now, all sequences have finished running. So let's have a look at our acquired images in the image viewer. Let's start with our black blood images. Here, we want to make sure there are no cysts or fluid collections in the extracardiac anatomy. We're also checking for pleural effusion. When the patient has poor pulmonary or heart function and lies in a supine position, they often collect fluid in the lower back part of the lungs. This fluid collection is called pleural effusion and would show up here as a bright pool of fluid. But in a healthy patient, which we have here, we don't see any such effusion. Let's now look at our bright blood sequence. Here, such pleural effusions would stand out even clearer because water appears bright in this sequence. The T1 black blood sequence we looked at earlier is a hybrid. So it also shows still water content as bright, but not flowing water like blood, which will appear black. Next, we'll review the 4-chamber here. The 2-chamber over here. And the 3-chamber, which is our left ventricular outflow tract. Unfortunately, in this case, the LVOT view doesn't display the aorta clearly. But in many cases, this view gives a great look at the aorta, especially when you can see the mitral valve leaflets. We also acquired a short axis CINE stack. You can see it here. If I go back a few slices, just before the final one, we can spot some pathology. This is where it becomes critical to decide if an image needs to be repeated. We need to clearly review the subendocardium of the left ventricle, this inner layer right here. We also need to review and outline the epicardium, the outer contour of the myocardium. For the right ventricle, we need to check the subendocardium as well. And ideally, we should also be able to see the epicardium, which would lie around here. These are the types of contours that cardiologists or radiologists will draw when assessing cardiac function. They compare the endocardial border during systole and diastole. The volume difference of the endocardial cavity between systole and diastole gives us the ejection fraction, or EF. That's the single most important number to assess heart function. But when we're talking about viability or transmurality, we're not just looking at volume. We want to see if a myocardial infarction affects the tissue, like here, where the infarction is visible in this region. As you can see, some of the myocardium remains thick, especially toward the epicardium. This means the damage is limited to the subendocardial region. In that case, we describe it as subendocardial gadolinium enhancement or subendocardial infarction. There's still viable myocardium, and the subepicardial region may recover. But if the enhancement extends all the way to the epicardium, like in this more severe case, we call that transmural late gadolinium enhancement. This pattern suggests non-viable infarcted tissue. So this means almost all the affected myocardium has turned fibrotic or has a scar. There's also a third pattern, patchy gadolinium. This shows scattered enhancement in multiple regions, a little here, a little there. It doesn't follow the usual pattern of myocardial infarction. This pattern is almost never, or very rarely, consistent with myocardial infarction. It's more often seen in cardiomyopathies, or suggests the possibility of a cardiomyopathy. But these are the kinds of diagnostic considerations that clinicians, cardiologists, or radiologists make. Your main focus is to be sure that whatever you see in the myocardium is real, that it's actual scar tissue from gadolinium and not artifacts. Sometimes, to confirm this, you'll need to do a phase swap on your short axis, 4-chamber or 2-chamber views. This helps verify that the bright signal really matches disease and isn't caused by artifact. Finally, when you perform a cardiac MRI, remember that breathing artifacts are very common, mainly due to the effort required by the patient. Cardiac exams often need 20, 25, or even 30 repeated breath holds in a row, which makes the process tiring and hard to maintain perfectly. Besides instructing the patient to hold their breath, we can also avoid breathing artifacts by using respiratory gating, which is similar to ECG gating, but for timing to the breathing phase instead of the cardiac phase. So with that, we'll end this first part of the viability protocol video, where we specifically focused on cardiac function and morphology. To recap, here are the most important takeaways to remember. First, we generally prioritize SNR, then resolution, and lastly scan time. Cardiac viability, or MI protocols, need to clearly show the difference between scarred and healthy heart muscle. So we need strong SNR to see the contrast between these tissues, especially when looking at late gadolinium enhancement. Resolution also matters slightly more than scan time, as we need enough detail to see how deep the scar goes into the heart wall, so-called transmurality, which helps doctors decide if the heart muscle can recover. Second, we use 2 types of imaging techniques to assess cardiac morphology and function. We first use inversion recovery sequences, including black and bright blood imaging, to examine cardiac structure and detect extracardiac findings like effusions or thrombi. Then we use CINE imaging to evaluate how the heart muscle moves and identify areas with reduced wall motion. Both types of sequences use ECG gating to reduce motion artifacts and improve image quality. Third, make sure to avoid the common artifacts that can show up during cardiac MRI, which include motion, breathing, ECG mistriggering, flow, susceptibility, and wraparound artifacts. ECG mistriggering artifacts specifically happen when the ECG signal is poor, causing problems with cardiac phase timing. Some techniques we can use to avoid these artifacts are to use proper ECG gating, have patients hold their breath or use breathing navigation, use real-time CINE imaging, align the phase encoding direction perpendicular to major vessels, increase the bandwidth, and use fold-over suppression. Real-time CINE imaging is a newer technique that captures continuous images without relying on ECG signals, so it doesn't depend on accurate heartbeat detection. If you cover all these 3 points, you'll be able to do great cardiac viability MRI scans. Thanks for watching, and I'll see you in part 2 of this video, where we will cover cardiac tissue characterizations. Stay tuned.